Next speaker is Alfred Cheung. Alfred is the Chief of Nephrology at the University of Utah in the nephrology section, and he is going to speak about how to prevent kidney failure. Right, Alfred?
Close enough. Well, I would never be accused of being young, I guess that's for sure. But I'm really, really honored and humbled that Harry, out of everybody, asked me to speak, because I have really tremendous respect for Harry, not only being a nephrologist, but also as a really patient-oriented physician. So when he asked me to talk, number one, I never refuse, but I also have a little bit of trepidation about what I'm going to speak between Andy and him. That's going to be quite a task here. Now, how do I operate this? Let's see, forward. Does that work? No, blank. Now, that was a very bad thing I did. Okay. All right. Can it be prevented? I think that my assignment actually is, can ESRD be prevented? Feel free to ask me questions. If I cannot answer, I'll just pass you on to Harry. But make it a free forum. So the answer is sometimes, all right? That's always a safe thing to say. And it really depends on the underlying kidney disease, which I'll illustrate in the next slide. And it also depends on, like anything else, we can always blame it on genetics. If oral fails, always blame it on genetics. But I think that's obviously true for some type of kidney diseases. And there are some external factors, such as environmental factors, but also what kind of treatment of CKD you are talking about. So it sometimes can be almost arrested. So this is an example that Giuseppe Romuzzi from Italy have published a few years ago. The title is really that's the decline in GFR, the glomerular filtration rate, varies depending on the disease state, and from one patient to another patient, but is also accelerated in those with proteinuria. And we heard Andy already talk about it. Proteinuria is really important, and I will also pound on that aspect as well. So on the axis here, you see the time after diagnosis, and the y-axis, you see glomerular filtration rate. So, for example, some kinds of polycystic kidney disease, you will see that it might be stable for a while. Here you have a long scale here, but in about 30 years or so, you have a decline, quite a substantial decline of GFR down to almost zero. Now, another example would be something like type 2 diabetes in perhaps about 40% of the patient. You develop CKD and may not develop ESRD, depending on whether you die first or not, which we'll talk more about. But sometimes some awful kidney disease, which you obviously should refer to Harry, which is something that I don't like to deal with either, which is primary focal sclerosis. These people have pretty nasty prognosis, especially those with proteinuria. So Andy has similar graphs show you this, and I do want to point out on the y-axis here is the number of patients in thousand, and X number is the year 1988 to 2006 over those 10 years, what happens. So number of prevalence dialysis patients has gone up to about 350,000. And the incidence of ESRD is also going up, but looks like it'll be plateauing. And some people have attributes this to the discovery of ACE inhibitors in the 1990s that used to forestall progression of kidney disease. Now, I don't know whether Andy would like to claim the credits for the Indian population that they have instituted, but many nephrologists around the country would like to claim this credit and saying that the flattening of the curve for the incidence ESRD is because of some of these strategies developed in the 1990s. So Andy alluded to the fact that diabetes is important as a cause of ESRD, particularly in the Indian population. So this is a pie graph to show you that the primary kidney disease at the start of dialysis initiation, as you can surmise, that's the yellow pie is diabetes, about 45-50%. Perhaps not so much in Utah, but about a quarter or so around the country is attributed to hypertension. Attributing the kidney disease to hypertension is a little bit of a wastebasket diagnosis. It could easily be the kidney disease causing hypertension rather than the hypertension causing the kidney disease. But there's no question in anybody's mind that hypertension can cause kidney disease. ESRD accelerates chronic kidney disease. And the others are others. Okay, it's glomerulonephritis and others around about 13 or 10%. So diabetes is very important, no question. Now, the next 2-3 slides I'm getting to you have perhaps seen this slide many, many times before. And the point I'm not trying to make here is not just only obesity is bad, but a couple of newer concepts in the last few years, I think may be a little bit new to some people in this audience that I want to emphasize. The evil sugar. The emphasis here is that sugar is made up of both glucose and fructose. And there's one school of thoughts that glucose is actually not that bad for you. It's really the fructose in the evil sugar. Okay. So many people understand that's glucose. People eat a lot of, drink a lot of Coca-Cola, and eat a lot of delicious desserts. They get fat and obese and get diabetes and so on and so forth. So, but I think perhaps slightly less recognized is that glucose actually, in a maladaptive state that actually causes either cells inflammation and could actually develop diabetes, not only worsening diabetes. Fructose is another interesting story that, if you have not heard about, is really quite interesting. That Rick Johnson in Colorado has championed this, and that this component of the evil sugar actually causes hyperuricemia, which also then causes hypertension. Okay, so do not blame it all on glucose. So before we talk about whether kidney disease can be arrested or not, we also need to know what is the natural history of CKD, right? So we all, unfortunately, most people at least, I am definitely one of the forerunner on this, my organs deteriorate with time, right? So it's been said that the normal people decrease the GFR by about half to 1 mils per minute after age 30. Except for Chris Rich, nobody is under age 30, right? I mean, it's really horrible, okay? Age 30, approximately. Actually, Chris Rich is not under age 30. He just looks like age 30. So, but in CKD, GFR decreases, let's call it 2, 6, 10. We'll show you some more example, right? So if you decrease half a mils per minute of GFR per year, you don't really have much CKD to speak of, right? I'm sure my brain decreased much faster than that. Right? So in this MDRD study, which is where the MDRD equation come from, where you estimate the eGFR, right? You have a variety of disease, mostly non-diabetic. Okay, actually, this is back in the late 1980s and early 1990s. 85% of these patients progressed. This is before ACE inhibitor ARB became very, very prevalent. Okay. So one of the things that I'm sure everybody would pound on is early recognition, which is trying to reverse things that's readily reversible, such as urinary tract obstruction. And if there's CKD is not CKD, but what you really hate to miss is something that requires other than garden variety treatment, such as ACE inhibitor, ARB, so on and so forth. What example, what if you miss vasculitis? What if you miss lupus nephritis? An ANCA-positive GN, right? That would be really horrible, right? So one of the clues that you get out of here is active urine sediment on urinalysis. That's one of the clues. Okay. So the serum creatinine, and Harry will talk about some more, is insensitive and unfortunately even ignored because it changes within the normal range. So early recognition is important. As Andy said, that everything treated early is probably the better for you, unless the treatment is worse than the disease, right? So there are some hypotheses that CKD may be a form of recurrent small boluses of AKI, of acute kidney injury, or at least exacerbated by it. So naturally, if you can prevent this mini episode of AKI, you'll be better off. So these things are quite self-evident, but I just want to please allow me to remind you, is fluid depletion. Blood pressure too high, the long run is bad. Blood pressure too low acutely is very bad for the GFR, okay? Very bad. Obstruction we talked about already. Contrast dye, that's Chris Rich talked about, is also bad. NSAID, even though COX-2 inhibitor may be okay for the GI tract, it's definitely just as bad for the kidneys, NSAID, right? ACE inhibitor ARB, why did I put it in there? Well, in the long run, as we'll talk a little bit more, it probably is protective. In the short run, it can definitely decrease the GFR, as you see it quite not infrequently. So, and then obviously drugs, other drugs can cause either direct toxicity or can cause allergy, which is what we call interstitial nephritis, or AIN, acute interstitial nephritis. The intervention to slow down the CKD progression, I put it in two categories. One is the well-established one, blood pressure control, ACE inhibitor, ARB, glucose control in diabetes in the early stage. In the early stage, I do not know the data when your creatinine is already 3 or 4, whether tight glucose control is good for progression of kidney disease or not. And the ACCORD study will show you actually may be bad for cardiovascular outcome. Inconclusive or weaker evidence, what other interventions? Protein restriction, iffy, plus or minus, okay? Lowering LDL cholesterol, plus or minus. Tobacco, specifically for kidney disease, is probably bad. Its evidence is not great, but it may affect the renal arteries or the smaller vasculatures, and then obesity. Now, I will show you one slide each on blood pressure and obesity for the general population in the next two slides here. One, blood pressure as a risk factor in ESRD, and Mike Clegg and Johns Hopkins published this in 2003, where they did the Mr. Fit study, which is multiple risk factor intervention trial, and looked at over 330,000 patients, right? What he found is on the y-axis is the year after screening, and the axis is ESRD. These are pretty general population. You might not be able to see all the colors all the way up, but in essence, what it says is that when you have worse and worse blood pressure, you get more and more chance of developing ESRD. Okay, now this is general population. We are not talking about some CKD patient that Harry's in his clinic. Okay, but I do want to point out to you, what we call optimal now is less than 120/80, and what we call high normal now is 140/90, right? But even though it's a gradual, very logical progression of these lines, but what is important to find out is that the top 3 lines are really the troublemakers, right? The other lines are kind of more bundled together, right? And what is this purple, I don't know what's called purple, or a pink line, okay? Which is stage 2 hypertension, 160/100. The next stage up is 180/110. I hope you would never allow the patient of this kind of blood pressure running around, right? So even though there is a grade between blood pressure and also development ESRD, we really talk about very nasty blood pressure here, right? So what is being bundled down here is still really under debate. To what extent you should be controlling blood pressure below 140 is really not that well known. We know that blood pressure nasty, we talk about 160, 180, 200, okay? Okay, well, BMI. Well, the slide I showed you 2 slides ago may be slightly deceiving. I said obesity is plus or minus, perhaps weak evidence. Does obesity really worsen chronic kidney disease progression? I am not sure. But what this slide showed is Northern California Kaiser, okay? So Andy has friends in Southern California Kaiser. I have friends in Northern California Kaiser, and CSU and UCSF, right? What he showed in Annals of Internal Medicine 2006 is that high body mass index predicts ESRD. Okay, these are 320,000 health screenees for healthcare, followed for around 26 years. As you the body mass index, using the index around 18 as 25 as reference, the fatter you are, the more likely you're going to get ESRD. Now, whether you can ask the question, so some of the people 26 years past has developed diabetes, that's not being answered here. It could very well be, okay? Now, this is a quiz question to kind of wake you up a little bit. Who is this? Oh, no, okay. Now, this is going to get tougher, okay, as the hour goes on. It's not going to be as easy, okay? Diabetic nephropathy. We heard that the hallmark is proteinuria, but we also learned from the American Indian population, some of them may not have that much proteinuria, Some of them might be small vessel disease, ischemic nephropathy, and not necessarily always basement membrane disease. Okay, but nonetheless, proteinuria is really a hallmark. So George Barkers from Chicago told us years ago that control of blood pressure is even better than glucose in diabetes for the prevention of cardiovascular disease. That's what he claims, right? Look at stroke. The orange bar, you have a tighter control of blood pressure. You can decrease it by 45%. Glucose, only about 5%, right? Diabetic endpoint, diabetes, death, microvascular complication, blood pressure control always wins. Okay, that's what he told us. Okay, it's probably true. Okay, but notice that the tight blood pressure control there we are talking about is 144/82. Okay, much below that we don't really know. Is that really better or not? And what's even more confusing to us, and don't blame me, I have nothing to do with generating this data, is the Accord trial published a few months, or 1 or 2 months ago in New England Journal, telling us that tight control of blood glucose actually have worsened cardiovascular disease. Okay? I don't really know all the explanation for this, but that's what the data shows. Now, but Harry did not ask me to talk about cardiovascular disease, right? He asked me to talk about renal disease progression. So that's what I showed in this last slide. George Barkers also told us the better the blood pressure control, the slower the progression. So on the x-axis is MAP, mean arterial blood pressure, 98 to 110. And the y-axis is change in GFR. You can see minus 2 mils per minute, minus 4 mils per minute. The bottom is minus 10 mils per minute per year. The lower you go, the worse off you are. And what this line that George Barkers drew was that the higher the blood pressure, the faster drop in GFR you will have over time, right? So, for example, 108 is 140/90, right? That's what we call pre-hypertension nowadays. But if you go down to 130/80 and extrapolate, you come down to maybe 1.5 mils per minute. Now, please remember what I told you. Age 30 and beyond, how fast do you drop your GFR? Half to 1 mils per minute, right? So this is pretty darn close, getting there, okay? It's not as, you don't want to be too, we like to be greedy to have no decrease in GFR, but it's not very likely, okay? So that's what it shows. That's what normal is, approximately half and 1 mils per minute per year decline in GFR. So the better control of blood pressure, perhaps the better you are. Here we're again talking about a relatively narrow range. Below 130/80, are we sure? Absolutely not. So we talk about blood pressure. What about glucose control? Well, the DCCT trial for insulin-dependent diabetes told us a long time ago that in the two upper curve would be urine albumin over 40, right? So Andy told us that 30 is probably bad already. So the lower curve is even worse, over 300 at baseline, okay, is to ask the question that does intense treatment of glucose, does it help or not help? And the answer is yes, it would, those two curves refer to the end point. How many patients end up with albumin over 40 or end up with urine albumin over 300. So tight control of glucose actually decreases albuminuria. But I also want to emphasize that this is really not a long-term control of glucose demonstrating that you have a decrease to ESRD, which is what Harry wants me to talk about. What this says here is that if you control glucose, when the GFR is still over 100 mils per minute, it decreases albuminuria. That's all we know. Okay, so don't be so rigorous about controlling glucose for the purpose of decreasing ESRD yet. Perhaps for neuropathy is good, retinopathy might be good, okay, but we really do not know how good it is for decreasing ESRD. Again, the Accord trial, the troublemaker, even told us that it does not help with cardiovascular disease protection, okay. ACE inhibitor for diabetes, this is Ed Lewis's back in 1993, 17 years ago. Tell us it's captopril, which we don't use as much now anymore, right? Would actually, this is now a little farther along in the ESRD chain. This is prevention of death, dialysis, and transplant, not only just a little bit albuminuria, right? So Ed Lewis would tell us that, yes, ACE inhibitor is good for you if you have type 1 diabetes associated diabetic nephropathy, right? Consequently, I'm lumping several studies into this slide, which say that in type 2 diabetes, the IDNT trial, the Renal trial published a few years ago, which showed that using sartans, right, ARBs, would also slow down the progression of kidney disease. But furthermore, if you go back in the earlier stages, the IRMA2 and even the Benedict trial, when you started with normal albumin urea, using a ACE inhibitor in the Benedict trial, or using an ARB in the IRMA trial, or ARB and IDNT or Renal trial, they all seem to slow down the progression of kidney disease, at least in terms of albumin urea. Right? So here, again, I want to emphasize that if you want to give the patient an ACE inhibitor and ARB when the patient is still normal albuminuric or microalbuminuric, yes, you can slow down the progression of kidney disease to less development of overt proteinuria. Whether it really slowed down progression of end-stage renal disease, I'm not quite sure yet. Okay. So, but against Harry always give me a very tough assignment. He asked me, can it be prevented? Can it be halted? Not just to slow it down, all right? So I'm going to show you a little bit for diabetic nephropathy. Halting CKD, multifactorial approach. Assuming that if no intervention, you drop your GFR from 50 down to 10 when you have to start dialysis in 4 years, okay? Lowering blood pressure itself is important, we know. ACE inhibitor ARB may help some more. And lowering blood pressure, ACE inhibitor ARB, maybe lipid, maybe glycemic control. I already told you I'm not sure, okay? Maybe exercise and diet, maybe smoking, we're not quite sure either, okay? Slow it down a little bit more. But I didn't draw this line flat, right? Because everybody's GFR drop, right? 0.5 ml to 1 ml per minute per year, okay? So, but maybe it'll be helpful. So what is the end result of this? Well, the Europeans, especially those in Denmark, they're very aggressive. They follow in this Steno diabetes clinic in Denmark, do a prospective observational study. It's not a randomized trial. They have 301 consecutive type 1 diabetic patients with already established albuminuria. Okay, and they treat them very aggressively with a lot of approaches, right? Blood pressure control, ACE inhibitor, etc., and etc. And they're very aggressive. They do clearance using something called EDTA clearance every year for 3 to 14 years and see what happened to their clearance, okay? And lo and behold, about 31% of them has remission as defined by albumin urea dropping more than 30% down to below 200 milligrams per minute for at least 1 year. And they also have regression. 22% actually get better. The GFR decline less than 1 ml per minute per year, which is, you would define it as normal, right? Now I want to put a little bit of caveat on this. He is calling this remission, regression, and yes, these patients started off with substantial albuminuria, okay? And then they either decrease in albuminuria, GFR did not decline quite as fast, okay? But remember, not all diabetic patients go into to develop nephropathy either, okay? But nonetheless, I think it's a sound approach to do all those good things. How about really reversal? Well, pancreatic transplant does it for you. Here you don't really need to be a renal pathologist to see that all this pink blob inside the glomerulus is bad, okay? There's a lot of sclerosis here. 5 years, not that much change yet after pancreatic transplant. But if you can achieve normal glycemia with pancreatic transplant, 10 years, all those pink blobs, most of them gone away, okay? So normal glycemia can really help the kidney in diabetes as well. Now what is this? Well, I picked the slide, the game that the U.S. actually beat the Canadian, okay? I didn't want to put the one that was a bad one. All right, how about the non-diabetic kidney disease? We emphasized the last 15 minutes on diabetic kidney disease. How about non-diabetic kidney disease? Is blood pressure control important? Here I will give you a little bit caveat if you're not familiar with it. This is out of the MDRD study, which only about 3% of the population has diabetes. So this is really non-diabetic population, okay? So on the left panel is saying that if you have blood pressure 140 over 90 compared to 125 over 75, Okay, so very tight control of blood pressure versus kind of pre-hypertension level. If you don't have much proteinuria, less than 1 gram per day, lowering the blood pressure with very, very tight control does not help the progression of kidney disease, the y-axis being rate of GFR decline. But if you have more than 3 grams per day in the right panel, then very tight control of blood pressure, 125/75, will have a slower decline compared to the green dot, which is the blood pressure 140/90. So the level of proteinuria is important. Likewise, is ACE inhibitor important or not? Also depends on the proteinuria. So this is the African American study in kidney disease and hypertension study. And a few points I want to make here. These are the patients with the subgroup with urine proteinuria greater than 0.22, which translates to approximately 300 milligrams of protein a day. In these particular patients, Renal, an ACE inhibitor, which is showing that in the yellow line, is better off, not as fast decline in GFR compared to amlodipine, the calcium channel blocker. Okay, and then so that is what that shows. In patient with significant proteinuria, ACE inhibitor is better than calcium channel blocker. Furthermore, I want to show you this. In this particular studies in amlodipine, 3 years out, you drop the GFR by about 18 mils per minute. Okay, so even divided by 3, we're talking about 6 mils drop in GFR here, right? So as opposed to normal, we kept talking about half to 1 mils per minute per year. Okay, so when you ask the question, well, how fast the kidney disease progress, really depends on how well the treatment is. Okay, so it's really quite variable. So again, asking the question, should you use ACE inhibitor or ARB in non-diabetic patient? In diabetic patient, because many of them have proteinuria, I think the answer is quite clear. But non-diabetic patient, in the meta-analysis of 11 randomized trial, what was found is that ACE inhibitor is associated with a low risk of ESRD, quite substantial decrease, relative risk 0.69, meaning 31 decrease in relative risk, right? Furthermore, it's noted that the ACE inhibitor benefits patients with significant proteinuria, but not so convincingly if you only have about 300 milligrams per day of proteinuria. So in these patients who does not have significant proteinuria, then you really have to balance the side effects of ACE inhibitor with perhaps not that much beneficial effect. Okay, so proteinuria is important. I think Harry will probably talk a little bit more about ACE inhibitor ARB combination to decrease proteinuria, to slow down progression of kidney disease. How many people in this audience believe that the combo is useful? Hey, good for you, okay. So this paper here has been retracted, okay. This is done in Japan. Combination treatment of angiotensin receptor blockade and ACE inhibitor in non-diabetic renal disease, the CORBIT trial. Many people hang their heads on this trial for a number of years. And now, several months ago, they retracted it because apparently cheating, okay. Very, very bad, very bad. So the proteinuria, I show you different states data. So the conclusion of proteinuria is that it portends poor kidney prognosis. You know, proteinuria is bad. Andy already told you that, right? It also modulates response to blood pressure control. If you have not much proteinuria, it probably doesn't help that much. The lowering the blood pressure from 140/90 down to 125/75 doesn't help that much. We're not talking about 160, 180 systolic here, remember, okay? And also modulate the response to ACE inhibitor ARB. If you don't have that much proteinuria, perhaps if you have less than 300 milligrams per day, ACE inhibitor ARB in a non-diabetic patient might not be that helpful. Diabetes, please go ahead. ACE inhibitor ARB. Okay. Who is that? Hey, it's getting tougher and tougher. She's wearing a mask there, right? I hope that you will not be able to see that. Okay, all right. Now I'm coming to the last segment of my talk, which is prevalence of CKD in U.S. And Andy told us that these different staging, which I've down below, greater than 90, and then 60 to 90, and 30 to 60, and Andy told us that this might not be that great a classification. But the important question here to ask is that we have, 5.9 million people with stage 1 and 7.6 million with stage 3, 30 to 60. And the data is quite consistent that when you come to stage 4, GFR 15 to 30 minutes, you only have 400,000. This is the prevalence of CKD in US. That's what they're asking. So where did these patients go from stage 2 to stage 4? I wish they have moved out of the US and go to Canada or someplace. That's why it's lower, okay? But it's not the case. Unfortunately, it's likely they died, right? That's the case, right? So that's the question that I'm going to try to address right now. So that's the issue, and this is what Harry asked me. Can you prevent ESRD? This is how I address it with my patients in the clinic as well, okay? Patient asked me, well, Dr. Cheung, do I have to go on dialysis? And I don't mean to be funny or obnoxious, right? But I said that, well, everybody's GFR drop half to 1 mL per minute. If you live long enough, the cardiologist would not let you die, the pulmonologist would not let you die, the cancer doctor have all kinds of monoclonal antibody. What are you going to happen to the kidney? Eventually got to fail, right? So you have a choice. Yeah, you develop ESRD when you're age 120, or you die, right? So I think here is the debate. Do you want to die, or do you want to get ESRD, right? It sounds kind of awkward, but that's the reality that we all have to face, right? So the question that comes up always is that, are you likely to die or likely to get an ESRD? And this is one of the studies that's been quite widely quoted. So when you have stage 2 CKD, Andy told us that even though it's not perfect, it's approximately 60, 90 mL per minute. Okay. Yes, you can call these people CKD, but Harry and Andy said they're not really CKD, all right, unless you have bad proteinuria, right? So here, the blue bar will tell you, these patients with kind of wimpy, little bit of CKD, they are much more likely to die, the blue bar, than to develop ESRD. The yellow bar, right? This is the chance of you developing this thing, right? Stage 3, the ESRD inch up a little bit, but also the blue bar, you're more likely to die also, right? But obviously, intuitively, you will know, the close your GFR get lower and lower and lower, you're not dead yet, then your chance is going to be more and more likely to develop ESRD. If your GFR is 12 mL per minute and you're still alive, yeah, you're going to be quite likely to go into ESRD, right? I mean, that's quite obvious, okay? So the question that we sometimes ask, and you have to also address the same question, and obviously Harry addresses, is that do you prepare for chronic dialysis or not? Should Harry send the patient to the surgeons? Would you be in a hurry to send the patient to get a fistula or not? That you have to take into consideration the age, right? If you are 92 years old and you're stage 3 CKD, probably not the greatest candidate to put a fistula in, right? I mean, that's obvious to you, all right? But so don't just because the patient is stage 3 or stage 4 make that decision. Obviously, comorbidity, right? This is something you always evaluate. So we already have end-stage heart failure, liver cancer, etc. The other question is not really what is the GFR, it's how fast does it change? I already showed you different curves, right? If you have focal glomerular sclerosis, it could be pretty bad, right? So if it changes very fast, I might even put the fistula in with GFR of 18 mL per minute if it is declined very, very fast. If the patient is really rock stable with creatinine 2 of the last 5 years, I don't care if it's 2.5 now, right? Or stable at 4. So what if it's 4.3 now? It's not that exciting, okay? Right? And finally, as you all know, it will be the psychosocial factors. Right? So all this thing has to be taken into account. Now, this is getting tougher and tougher. Can you guess this one? It's also in the Vancouver Olympics. Actually, I don't remember his name. Steve Holcomb, is that right, from Park City? Or the guy who, I think he had some blindness in his younger age, but he led our USA team to win the championship in this Olympic event. All right, so again, even though Harry asked me to address, can ESRD be prevented? And I thought about it carefully. I said, can I change the title to also talk about, can chronic dialysis be prevented? Well, what's the difference between these two, you think? Obviously, you can get a transplant, doesn't mean in chronic dialysis, right? But what is another difference? Well, I'm going to tell you this here, okay? This shows that the serum creatinine at the initiation of chronic dialysis in the U.S., and I think Harry is going to show you the more local data in our region here. The year 1995 to year 2007, the 40, it's just meaning the slide number. I forgot to take it out. I'm sorry. Okay, so this is a serum creatinine at the time you initiate dialysis. In year 1995, let's say that all patients are black line. Starting serum creatinine was 9, okay? And then in 2007, it was down to, what is that, maybe 7 or something like that, okay? Now it's probably even lower, okay? Well, why do you think it is? Well, Andy told us that maybe it's smaller muscle mass. Do you think that people get smaller muscle mass between 1995 and 2007 for the same GFR? You think likely? I don't think so, okay? I don't know for sure, but I don't think so, all right? So I think this translates to, is the patients getting dialysis really earlier with higher GFR, okay? So why? Okay, why? That's what I asked the question. Because he asked me to address how do we prevent ESRD, and I'm asking how do we prevent chronic dialysis, right? Well, tell me, why do you think we're starting dialysis earlier? What do you think? Well, one of them is perception that early dialysis is medically better. The earlier the better. Some people coin this phrase, healthy start, okay? Of course, some dialysis company like to promote that phrase, healthy start, right? The earlier you start, the better off, which is not proven, okay? I won't go into detail. We can discuss it in the answering question, but it's not proven at all, okay? The payment system also favors more comprehensive care in ESRD. Here, I do like to spend about 60 seconds. You know that in the ESRD, once you plug into the system, Medicare start paying, you get your EPO, right, your ARNAPs, epoprotein, you get dietary counsel, you get all the counsel, the whole team of ESRD team taking care of you, right? In the CKD, you struggle, Harry struggle, I struggle. How do you find this counsel, that counsel, right, to support him? Even though, yes, CMS now pay for dietary counsel, which is very kind of them, okay, right? But we don't have as good a supporting structure, a team to take care of CKD patient as we do with ESRD, because Congress passed a law and said that we take care of dialysis patients. They didn't pass the law and say that all chronic kidney disease patients have the same entitlement to get ESRD care, the same as ESRD, right? So Jonas Bergström, who was a famous nephrologist in Sweden years ago, very sarcastically, one time, leaned over and would listen to a lecture and talk about early start dialysis in the National Nephrology meeting. He leaned over and said, Alfred, if you guys in the U.S. cannot take care of patients and just have to put them on dialysis when you can take care of them, then put all your CKD patients on dialysis, okay, at any stage, because that's where you can take care of them. Well, I was very embarrassed, obviously, all right? This is how our payment system is. It's nothing to do whether Harry is capable or not capable of taking care of patients, or you are capable or not capable of those patients, right? That's our payment system. The last point I'm bringing up about why starting dialysis earlier is definitely not politically correct, but I'm going to stick my neck out and put it there, okay? It's dollar, okay? I cannot prove it to you, but I cannot help to think that some patients are started on dialysis earlier today because of money in somebody's pocket. If you want to get more answer, maybe you should ask Harry, okay? All right, I'm going to switch. Harry would not ever do that, I'll tell you, okay? I want to emphasize. That's why I want to emphasize, I mean it 100%. I had tremendous respect for Harry, not only as a nephrologist, but also as a people-oriented doctor, right? I cannot help. I don't have data. Don't ask me for data, okay? But I tend to think that might be, unfortunately, might be one of the motives. So this is actually my second last slide, is that we have the World Kidney Day by the Kidney Foundation, where we want to popularize to the notion that not only high blood pressure is bad, coronary artery disease is bad, okay, cancer, we need to pay attention, as the kidney disease is common and it's harmful, and in many extents it's treatable, at least can slow it down. We need to raise the awareness. So this is my final slide. Who is she? What's the name? I think it's Queen Anand, it says her name, but she is very good. Thank you.